We're going to get started in just a minute. We're going to let some more people in as we're straight up 2 o'clock. I am the president CEO of Health Agents for America, and I love to start exactly on time. But this is such an important issue that I want to give everyone a chance to get in because I think a lot of people want to hear what Tony has to say. So we're going to give everybody a few more minutes. Hopefully everybody survived open enrollment. It was pretty daunting and pretty horrible.
I survived, but I came out with a severe limp.
I know. I think I need mental and nervous medicine now. We'll give it one more minute and then we're gonna go. There you are. I saw your face for a little. There you go. You're back. But you're on mute for some reason.
Yeah, my camera
He's
Okay.
lighting was
hiding.
being a little weird to me.
He's just trying to hide.
Yeah, he is. I don't blame him.
I don't blame me either. I am not that attractive.
No, that's not true. Again, my name is Ronell Nolan, President, CEO, Health Agents for America. Welcome to this very important webinar. We are honored. And not only am I honored that Tony is going to present this very important topic, but I'm also honored that he's a HOFA member and a HOFA presidential board member, which personally means a lot to me. Um, I was at the NAIC, which is the National Association of Insurance Commissioners, last week, and CMS Medicare showed up for the first time ever to a meeting, and their entire staff was there. Look at Rebecca doing the happy dance. It's true. I said in our board meeting yesterday, I hugged every one of them little critters, making sure that they remembered who I was. But they asked us personally to comment about this topic that Tony's going to go over. So this is very important that we share this with our colleagues, that everyone comments either positive or negative. So you want to come out, comment either way. But in order to comment, we need to understand what's in the proposed rules. So thank you so much, Tony. You're amazing. And I'm going to give you the floor and shut up.
Well, thank you. I appreciate the introduction. Give me a second to get my screen share for you guys, and we will get started. Un momento, por favor. All right. So everybody should be able to see my screen. Say aye. Good. So we are going to go over CMS proposed final rule for 2027. And I'm specifically going to go after it based on what changes impact Medicare agents, right? So we're going to look at what changes we have coming and certainly also what doesn't change. And of course, this is an educational webinar only. So a couple of ground rules and expectations. Most importantly, this is a proposed rule. It ain't final. So don't take this and run with it yet. This is just proposal stuff. It would apply for 2027, which means it would technically, if it is, or what parts of it are approved, would kick off October 1st for AEP of 2027. So this webinar is educational only. Do not take this as legal advice. And again, I'm going to focus on how the rule specifically impacts Medicare agents. It will be easy for you as an agent to decipher how it would further ripple impact your beneficiaries. So why the rule matters? Well, number one, CMS is changing their tone a little bit. They are moving away from the strict agent micromanagement and towards a more balanced approach that's going to emphasize plan responsibility. Um, they are basically less micromanagement for us means fewer prescriptive rules, allowing more discretion for us and how we actually communicate and assist our beneficiaries. So they are putting more accountability on plans. So the plans are now further or more expected, I should say, to ensure compliance, to ensure that agents do not have misconduct, and that is a shifting oversight from CMS more on the plans. But ultimately, it's going to give us greater flexibility. We're going to gain more operational freedom to engage professionally and efficiently with our Medicare beneficiaries. So there's about 14 topics that are in the final rule. I dropped them into 4 agent buckets. Basically, marketing and sales flexibility, which includes all the changes that give us more freedom in how we market and sell Medicare plans. I also created a bucket for enrollments and SEPs, some of the changes that happen there and how those election mechanics will operate. Also, there are some updates in Part D and creditable coverage. Some of it is just codification of previous rules that they are enforcing and saying they're sticking to, but they did make some changes. And then finally, star ratings and market impact in that regards. So what did CMS actually relax? Or at least what are they proposing that they're going to relax? Number one is SOA timing changes. They are proposing to eliminate the 48-hour wait period for the scope of appointment, meaning that you can basically run same-day appointments even if they're not a walk-in. They are loosening some of the restrictions on events for educational and marketing events where they can actually happen same day and same location. One of the biggest ones, in my opinion, is they are loosening up on advertising language restrictions. They're removing their sentence level policing policies and focusing instead on truthfulness and clarity without being overly strict on word usage. There's some new updates on the TPMO disclaimer, not only what needs to be said, but when it needs to be said. They're basically getting away from the 60-second time limit and allowing us to be a little more natural in that discussion. And then they're also dialing back on some of the call recording. They are not getting rid of call recording, but they are loosening some of the administrative burden on it. So advertising language changes. I want to dive into this one a little bit deep because this is where a lot of the gray area exists. Some of the other proposed changes are pretty cut and dry, like the SOA. Like we understand that. We don't need to dive into it. But there is a lot of gray area in advertising language. So this will be a pretty good meat of the presentation or the discussion itself. So number one, again, they're not going to micromanage individual sentences within ads. They're going to give us a lot more freedom in how we communicate benefits and details. It's going to be based on truth-based standards, right? So all advertising still has to be truthful, has to be accurate and substantiated, but no misleading claims and certainly no false urgency authority. But again, we are going to have a little more freedom in how we can, or the language we can use in advertising. Diving a little deeper, our current framework, basically CMS currently polices specific words and phrases, right? They tell us that certain terms are treated as automatically risky, even if they're true. So they've really been measuring us based on how something is said, whether it's accurate or not. But if you look at the proposed rule change, they are going to now evaluate advertising based on its accuracy, its context, the likelihood of whether or not it creates consumer confusion, and more importantly, whether the claims that you're making in the advertising can be substantiated. What this really means for you is that you're no longer automatically non-compliant just because you use a strong word, but you're still responsible to prove that what you say is true. And one of the biggest areas is in the use of superlatives. So what they are proposing is that, hey, superlatives are fine as long as they're truthful, they're not misleading, they're supported by evidence, and they're presented with appropriate context. So as an example, what would be likely acceptable would be language such as, hey, I have one of the highest rated plans in the county, assuming that you can prove that with star ratings, for example. Or, hey, I have a plan with some of the lowest premiums available locally. Or my plan is highly rated by CMS. And even further so, if you live in Travis County, Texas, like I do, where Devoted now has a 5-star plan, and it's the only 5-star plan, I could say, hey, check out Devoted. It is the highest rated plan in Travis County because I can substantiate that with the 5-star rating, and it's the only one with the 5-star rating. However, what would still be problematic would be vague blanket statements like, hey, it's the best plan for everybody, or it's the #1 plan out there if you don't have a cited basis to say so. or even more importantly, I have the most comprehensive plan available, because that is absolutely unprovable. So the key takeaway on this is understanding that, hey, superlatives are not banned, but unsupported absolutes still are. So if you're going to use a superlative, you better be able to back it up. Some clarification around usage of the words free or $0 in various cost language. What stays the same is the use of zero premium or zero copay has to be accurate. You cannot imply that all costs are $0, and you certainly must not imply that Medicare Advantage replaces original Medicare. What they are clarifying is the contextual accuracy over the rigid phrasing. So saying zero premium plan is fine, but implying that you're getting free healthcare is not fine, right? So kind of a practical agent guidance on that. Anytime you're going to use a cost claim, always pair it with implicit or explicit context. For example, we have zero premium plans available, though other costs may apply depending on the services, or maybe depending on usage, as another example. They are also putting a reduced focus on what I call magic disclaimers, or an increased focus on clarity. So they're really giving less reliance on the long boilerplate disclaimers that really nobody understands, and they're putting more emphasis on clear, plain language explanations and disclosures that actually reduce confusion. Now, with that being said, required disclaimers still apply: TPMO, plan availability, etc. So it's not a removal of disclaimers, but it is a simplification. Visual and applied claims, they matter actually more than exact wording. So CMS explicitly reiterates, and this is again is a reiteration because these things are already in there, but they very much hit these again to say, hey, even though we're relaxing on some of this stuff, we want to make sure that you understand that these things are still in play, right? So if you were using visual imagery or formatting that emphasizes a part of your advertising claims, like highlighting only the benefits without mentioning limitations, that's still considered misleading. Or using oversized free graphics, that's still a problem. Small print disclaimers that contradict your bold headlines, that's putting you in risky territory. The test really becomes, hey, would a reasonable, in reading your ad or looking at your advertising, would a reasonable Medicare beneficiary walk away with the wrong impression after reading that advertisement or looking at it? Whether it's TV, print, doesn't matter, direct mail, etc. And while it's not listed here, you're still not allowed to use the Medicare card, the actual Medicare card, or the John Smith sample card in your advertising. You have to use that little graphic image that they created for us. Enforcement focus as well as lightening up. So they are proposing to focus enforcement on actual consumer harm, not just purely technical, non-harmful errors. So you're going to expect the plans, not just the agents, to maintain compliance systems, and this will directly tie to better or greater plan accountability, but reduced agent micromanagement, right? If your advertisement or your stuff creates consumer harm, you're going to be under the microscope and probably in trouble. But if it's a small technical error, not going to be a big deal, probably just get some coaching, a little slap on the wrist, let's fix it. But because of that reduced agent micromanagement from CMS is specifically what they're saying. They're not saying reduced agent micromanagement from the carriers. They are saying specifically from CMS's vantage point. So there will be more reliance on the carriers to monitor us and any misbehavior when it comes to advertising, which means they're putting a lot more reliance on audits and pattern analysis. Now, I want to expand on that a little bit because I'm of the opinion that insurance companies are both greedy and lazy, and their greed drives their laziness. So they're not just going to automatically start auditing people because they have nothing better to do. They're going to look for patterns, though. They're going to look for people that make complaints, things that might be turned in, and stuff that they see. So if you get on their radar somehow and they find out that you're maybe using their logo without their permission, or more importantly, if you have a pattern of creating problems or false advertising or maybe abusing SEPs, that's where your carriers are really going to step in and start monitoring us at a higher level. So again, with advertising language, what is not changing? right? And this is super important. Even with all this added flexibility, you still cannot claim that you're affiliated with Medicare or CMS. You can't say that the plan is government endorsed. You can't imply that any enrollment guarantees eligibility. Can't use fear-based or coercive language. You can't misrepresent provider participation. That one kind of pisses me off that they, pardon my language, that they put that on us, because I'm all too aware of carriers that misrepresent provider participation. Uh, there was a carrier not too long ago that was sued and lost, I believe it was something like $51 million for pushing ghost networks out there. And I will tell you, they are still doing it. I'm not going to name who they are. You can maybe figure it out, but they're still doing it. But as agents, we cannot misrepresent provider participation, and we certainly can't misstate star ratings or benefits. So the truthful flexibility that they're giving us does not equate to relaxed integrity. So a safe lane for agents is to really just speak accurately, avoid absolutes unless you can prove them, provide context, not hype, match any headlines in your advertising to the fine print that you're also putting in there, and then assume that your visuals count as claims, and then let your documentation back you up. Now, I mentioned earlier that the TPMO disclaimers are changing. They're not going away, but they are giving us a lot more reasonable flexibility on it, right? We still have to use the TPMO disclaimer before we can explain any benefits in the Medicare space, at least Medicare Advantage or drug plans, but the timing is becoming more natural. Instead of having to do it in the first 60 seconds of any phone call, we now can do it anytime in the phone call, but as long as we do it before we start talking about benefits or an enrollment. They also removed the reference to ship. We no longer have to include ship, or I should say, assuming this is approved, we would no longer have to include ship in the disclaimer, but we still have to include Medicare.gov as a trusted online resource. So this really gives us a more natural delivery through a real conversation versus a rigid transactional feeling to it. SOAs are changing a little bit, or should be changing. Again, and I mentioned this earlier, they are looking at getting rid of the 48-hour wait period, which is awesome because now we can do immediate engagement, immediate presentation on the same day, regardless if it's outbound, inbound, walk-in, or whatever. So same-day appointments are fully allowed, and we can now, if it's approved, and I pray it is, we can also start doing SOAs at educational events. That is massive because it was so just completely abnormal and weird to throw an educational event, get a bunch of people interested, they fill out your PTC form, and then you call them and they're expecting you to be able to talk to them about plans and benefits. But nope, hey, we got to do another consent form, and then I got to wait 48 more hours. So they're looking at wiping all of that out to make it much more streamlined. If you're running educational events, you can scope them right there on the spot, get your PTC, call on the appointment, and be a true professional and immediately run into your presentation and close business. And then they are reinforcing that electronic SOAs are still permitted, right? So again, some of the things that they're putting in this final rule are just codification, right, or reinforcements of rules that already exist. So while they do say, hey, there's going to be no more 48-hour wait period, right? You can do scopes at educational events. We don't care if it's on paper or electronic, as long as it's in writing and you can document it and maintain it. So what has stayed in regards to scopes? Well, again, they're still required. They're not wiping them out. And they have to be in writing. So that means no verbal scopes on the phone. I know that, and we're guilty of this because we sell by phone too. So we do a lot of telesales, and we have been using a verbal scope on our recorded calls. Many carriers have told us it's perfectly acceptable. But CMS has no ruling on whether or not verbal scopes are acceptable. So according to them, it must be in writing, whether it's electronic, on a tablet, on a piece of paper, doesn't matter. You have to be able to get it in writing and be able to prove it at a later date should you be asked. And that is, again, maintained by the health plans to monitor that and make sure that we are monitoring our scopes. They still have us keeping them for 10 years. They haven't changed that at all. So if you're getting scopes, which you should be, you got to keep them for 10 years. Again, they're lightening up on educational versus marketing events. While you can't sell at an educational event, They are going to dial back the rules and allow you to have a marketing event immediately after your educational event in the same location, providing for a super smooth transition. All you would simply have to do is make an announcement that, hey, the education portion is over. I need everybody to break out their checkbooks because it's time to get started. Or maybe something softer. But in the same day is allowed where you can go straight from education right into sales at the same location without any wait times. They are updating the provider termination SEP. Used to be that if someone had a massive, and it had to be a super disruptive network problem, they would have to, the beneficiary would have to argue with CMS over it and get CMS to grant them an SEP to change their plan because of the very large network disruption. Now they're going to streamline that. And if basically the member can attest that, hey, my provider network is being terminated, whether it's their PCP or one of their better specialists, all they have to do is attest to that themselves, and they can work with you to turn in an application using that SEP code. And just like any other SEP, they'll get the month of it plus 2 following months. But they no longer have to go to CMS, verify massive network disruption to achieve that SEP based on special permissions. The member can attest to it themselves. So in an example scenario, the doctor leaves the network, right? The healthcare provider terminates their contract with the plan. That triggers the special enrollment. The member should receive a notice from the plan, right? So Humana, Aetna, whoever it is supposed to send them a notice that one of their main providers has terminated and is no longer in the network. So that gives them the SEP that they can attest to. Boom, agents can assist directly, write the app, use the proper SEP code, and simply get it pushed through. So they are also creating some clarity on SEP, or actually mostly SEPs, but pretty much all election codes. There are still certain election codes that CMS will maintain authority over. Things such as the Medicaid SEPs or LIS SEPs or the federal emergency SEPs. But then other ones are going to be more monitored by plans, such as the provider termination, loss of employer coverage, some of those different ones. So this kind of codifies some of the existing practice and reduces some of the gray area on who is really monitoring the which bucket of SEPs that are out there. There are some pretty big changes to, or I shouldn't say pretty big, but there are a couple of significant changes to Part D. A big part of what they did is they simply codified everything in the Inflation Reduction Act, said, hey, we're not changing any of that stuff, right? So there's still no donut hole. There's still an annual out-of-pocket max. There's still $0 in catastrophic phase, and there's still the manufacturer discount program. But what they have changed, or what they're proposing to change, is by creating a 73% actuarial value standard to determine creditable coverage on Part D. So if you have someone that is enrolled in Part A, they're on group insurance, and they have drug coverage, it doesn't have to be 100% as good as Medicare's drug coverage. It has to be 73% as good as Medicare's drug coverage. So some of the plans are not necessarily sending out those notices for discontinuing credible coverage or showing that. So it does put a little bit of onus on us, but they have also stated that, hey, we're not responsible to go out there and do actuarial value estimates. The plan sponsor at the group level is the one that really falls on, right? So the late enrollment penalty doesn't change, right? None of that changes, but the plan sponsor at the group level is the one that is supposed to inform their beneficiary, hey, our plan does or does not have 73% actuarial value. At the end of this presentation, I actually created a checklist that you can use as an intake form to help any of your prospects determine whether or not their plan is 73% creditable. So the agent guidance on that. So number one, you have to verify coverage, obviously, right? And again, I created a checklist that'll make it easy for you. But you do have to verify that they have coverage and help them. There's some basic document discussions you'll need to go through in regards to getting their notices, right? Ultimately, your responsibility is to avoid blanket assurances. Oh, yeah, all plans are creditable coverage. No problem. Like you have to stay away from that and make sure that they understand the process to work with their plan sponsor at the group level to verify that that drug coverage is creditable or at least 73% actuarial value against Medicare's drug coverage. And when you're uncertain, one of the suggestions was to recommend a low premium Part D plan just to take as a precaution, which I kind of want to go back to those slides. That all kind of makes me laugh too, because let's be honest, we pretty much can't write Part D plans anyway. So maybe that'll change in the future. Star ratings are getting adjusted a bit. So the overall star rating framework is mostly unchanged, but there are some differences that they're going to do in some of the calculations, right? So quality bonuses aren't changing, right? If you have a high star rating, you're still going to get your quality bonus payments. The reward factors all the same, and rebates fund the benefits. But what is changing is one, the health equity index reward is not going to be implemented starting in the 2027 star rating cycle. There's a bunch of low value measures. I didn't put them all in here, but I can get you a list of those. And they are phasing them out over not all at once, they're phasing them out over a time period. So there's some real low value measures that are used in star ratings. They're going to wipe all of those out, but they are adding, and I like this a lot, they're adding a new depression screening measurement within the star ratings. Because as we know, isolation and depression is one of the biggest issues that our seniors face. So I love the fact that they are adding that in and making sure that plans are doing their best to screen for depression, mental health problems, etc. And then finally, these changes obviously are going to influence plan design and market exits, but they will not affect us or our enrollment procedures. So what should we know as we come to an end on this presentation? It's pretty simple. Number one, stay informed of the proposed rule updates, because again, this is not finalized. Continue to maintain tight documentation practices. Don't start overhauling all of your current processes right now. Just be prepared for changes and don't panic. Thankfully, I don't think any of this is panic worthy. It's all, in my opinion, very good news that should it be approved, we're likely prepared for another nice bull run starting in 2027. So if it is finalized, get ready to update your SOA workflows accordingly. If you're doing any kind of telesales, you're probably going to want to revise your call scripts for how you're inserting the TPMO disclaimers, et cetera, et cetera. And then obviously make sure that you're following specific carrier guidance carefully. And as always, continue prioritizing compliance and documentation. So I did create a couple of takeaways. One is the 2027 proposed rule hot sheet. It's basically this presentation in a nutshell and bullet points. If you scan that QR code, it'll take you to one of my sync folders where you can download those two items. The other one is the Part D creditable coverage checklist. So if you have beneficiaries that are dealing with group and they're enrolled in Part A and they want to make sure that they're dodging Part D penalties properly, you can easily use that checklist to advise them and make sure that they are getting their stuff covered. Fairly simple. I will leave that up there. That is technically the end of the presentation. I know y'all gave me an hour, but that is the meat of it, and it took me a whole 27 minutes.
Well, thank you, Tony. I do want to reiterate what he said. These are proposed rules, and CMS explicitly said, you love something in here, you let us know. Because if you don't let us know, it could be some other yahoos that say, take it out, take it out, take it out, and they're going to take it out. So as an agent and broker, you need to stand up and send your comments in. It's through, and I'll get this out to everybody. It's through the CMS register. So it's really easy. You click on you want to comment. You can do it anonymously or you can do it as your name. So that's important. One thing I want to point out that's not in the proposed rules, but it's very important. On Medicare Part D and some of the other Medicare plans, we've lost commissions. And the way that carriers file their commissions with Medicare is they say we're going to pay between 0 and the max. So they're very shady about how they handle commissions. CMS told me to my face that was something they didn't like, and they were checking out how they could make insurance companies report. If I'm going to pay zero, pay zero. If I'm going to pay something, they have to stick to that something. So that's a step in the right direction as far as I'm concerned. I'm moving to the fact that zero should not be included in any filing. And I asked, did I need to do that regulatorily or legislatively? And they said you would need to take it to the Hill. Because I just think that that's just ridiculous. So that's something that Huff is working on, is getting that zero changed, that bottom changed. But CMS is trying to find a way to make the carriers report what that number looks like and quit hiding behind that zero between the max and then saying we filed, but we can't tell you what we filed. So I know there were a couple of
Yeah,
questions.
there's a couple of questions I want to clear up. Dawn asked, hey, did I understand correctly? Recorded voice OA is or SOA is not allowed in this rule? Not quite. They didn't address it whatsoever. So from CMS's standpoint, they don't tell you that it's okay to use verbal scopes, and they also don't tell you that it's not. All they said is like, hey, it has to be in writing. I've talked to several carriers that totally accept scope of appointment verbally, and I've had to turn a couple of them in, unfortunately, and I've never had a problem with it. But from CMS's standpoint, they want it in writing. But again, they also say that the onus is on the insurance company, not CMS. I mean, the onus is on us to do it, but the onus to enforce it is on the insurance company. So if the carriers are cool with voice SOAs, no problem. But CMS's opinion is it has to be in writing. So they're not saying you can't do voice SOAs, but they're also not saying you can. And then Justin's statement, correct in regards to the credible coverage. You could certainly contact the benefits administrator of the plan to get proof of that.
And if we're ever paid on Medicare Part D, which I hope that this is just a bad year, I would encourage you to partner with an agent that sells group insurance, because those employees will need to come off the plan if the plan is not credible, and they will need to be enrolled in Part D only. So if we get paid, this could be an opportunity for income resource. So I encourage you to make a friend on the group side.
And
And I'm
yeah,
sure
Rebecca, I
you'll have
wish they would
questions
get
on.
doctors to stop saying that it replaces Medicare. That's good luck with that one.
Right. And what I told Rebecca, and I encourage you, if there's something like that, even if it's not in the rule and you want to say it in your comments. CMS called me out on the last proposed rule, and they were like, Ronnie, you said a whole paragraph about what you didn't like and who you didn't like, and it wasn't about the proposed rule. And I said, I don't care. Y'all read it. So obviously it got your attention. So if you want to say it, say it. Take the opportunity. Good, bad, or ugly. And if anybody has any questions, if you want to raise your hand and ask Tony directly, or if you want to put it in the chat, I do want to recognize Rebecca Davis, who is our HOFA Medicare executive board member, and she has meetings every month, and she encourages HOFA members to join her committee. This is a very important part of our sales is Medicare, and we're making a difference. Things are changing. You can tell by this proposed rule, things are changing. I have an open relationship with the head of CMS Medicare now that I've never, ever had before. So we're moving in the right direction. But I want to thank Tony for doing this very interesting and easy to understand presentation. I encourage you to listen to the recording again. We'll send that out. Scan the QR code. I already did that. So you can, keep that information and use that to create your comments. And Tony, I'll let you finish this out.
Yeah, no worries. Yeah, if you haven't scanned that QR code that's on my screen, I would highly recommend you grab it. It's two easy takeaways. You don't have to register for them. It just takes you right to a site. You can download them immediately. One of them is just a hot sheet that goes over everything that we talked about in here. But the other one, more importantly, especially if you do a lot of T65 work like we do, will probably come in handy in regards to advising your clients on verifying they have Part D credible coverage properly. It's an absolute checklist that you can make sure that you're getting all of your I's dotted, T's crossed, even if you're not selling it, right? Because I know in some cases we're probably not selling the Part D plan, but we all, as people and professionals that care about our clients, we want to make sure they're getting it done right, because they're still going to get mad at us if we write their Medicare supplement or whatever it is, or we tell them, hey, delay Part B, but make sure you're not getting jacked on your Part D for credible coverage. So it's an easy checklist you can keep in your folder on your desk or somewhere to utilize. So just snag that QR code, super simple, download those, and you can take them away.
Tony, let me add one thing I forgot. CMS also told me that on the Medicare Part D website, that they were going to start adding a section that's going to capture the agent broker information. Now, my thought and their thought was maybe if it's captured, insurance companies will then, it'll be sent to the insurance companies. Maybe they'll be forced or, I don't know, to pay us. I did explain to them that if we're not paid, we can't help people. Therefore, we're not going to put our information on there. But just so y'all know that January 1, that site will capture agents and brokers if you would like to share that information with CMS.
And then you can make comments. It's actually, they've moved it though, from what I've seen in the past. It's not right there at the final rule on the Federal Register. They moved it to basically a comment on Executive Order 14192. If I remember correctly, that's the number, that talking about deregulation in Medicare. So they've moved it to that site. If you'll give me a second, I can get the link and drop it in there for you. I just got to stop my screen share. So if you need that QR code, hang tight. But I'll grab that and I'll throw it in the chat for you guys really quick. Bear with me just a moment.
The comment I just posted on the QR code doesn't go to them.
Oh, it does not go to them. That is my site.
You still have to go to the CMS register,
I have
Rebecca.
limited words on there. I ran out of space. Your site too.
So I'm dropping this link in the chat right now. That is to a site called Regulatory Relief for Medicare, basically. It's not necessarily direct comments on the final rule, but it does have several options that you can comment at the bottom of the link regarding regulatory change within Medicare. So you can definitely make comments and just kind of direct them towards, hey, in the final rule, this is what I'm reading regarding some of the regulatory relief that you've got in there. This I like, this I don't like. What about this? Yada, yada, yada. But they've moved it from where it usually is in past years, at least.
Well, Tony, I'd like to thank you so much. Thank you guys for joining. If you're not a HOPA member, please check us out. We'd love to have you. And I'm sure Tony will be available. If you want to email him, find him on Facebook if you have an additional question. He's an amazing and a great resource. But thank you guys. Have happy holidays and happy new year. And call us and let us know if we need it. If you need anything, if we can help. Thank you so much.
Yes, ma'am. Thank you.
You're a rock
Thank
star.
you, Tony.